Hello, everyone. My name is John Marigliano, and I'm one of the Child and Adolescent Psychiatry Fellows here at Prisma Health. I presented this talk earlier to the interns and first year child fellows at the research boot camp. But I want to thank all of you all for taking the time to listen to this video, and hopefully by the end, I'll be able to show you how the Hamilton can be a useful tool and something that you can use in your training while you're here. As an overview, essentially I've created a QI project to use the Hamilton and want to survey you guys after you've had a chance to try it for a while, and get your feedback, see how much it's impacted your clinical experience, if it's been added value, if there are reasons why you don't like to use it, things like that. I've created an epic dot phrase that you can use now that's live, and that makes it pretty straightforward and easy, I hope. But to show why you might want to use it, we're going to review a little bit some of the depression rating scales that are out there, particularly the PHQ-9 as it compares to the Hamilton, and some literature that kind of illustrates how the Hamilton might be a better tool for measuring depression severity. And then there's another video, which you can skip ahead to if you feel like you're already interested in trying the Hamilton, you just want to learn how to use the dot phrase. There's another video embedded in these slides later on that I'll demonstrate a walkthrough of how to use the dot phrase that I made in Epic. And then at the end, I'll explain how you can make some money by filling out these surveys. Your time is valuable, and I want to make sure that I compensate you for that, and I appreciate your feedback. So for me, the journey kind of began in third year when I was thinking about all the outpatients that I was seeing and noticing that we were using the PHQ-9 and the GAD-7, for everything, as it was kind of built into Epic. And I think around that time, I probably was starting to study more and look into things more for myself. And as everyone's probably familiar with the Mass General textbook, I was digging around in there and noticed, lo and behold, there's a chapter on diagnostic rating scales for psychiatry. And PHQ-9 and the GAD-7 aren't listed as metrics that they recommend using or described in any way in that textbook. And that led me to realize that these tools were designed primarily for primary care. And we'll look at some of the literature related to that, specifically related to the PHQ-9 in a little bit. So there's a whole bunch of tools that they listed that I didn't really have much experience with. Sometimes I would see them in literature. I was aware that they existed, but didn't have much clinical hands-on experience with. And that includes the Hamilton. As you can see here, it was established in 1960, and in a lot of literature you'll see it referred to as the gold standard for assessing the severity of depression. At the outset, I want to say that all these rating scales have pluses or minuses, and you can find numerous articles right now discussing some of the pluses and minuses related to the Hamilton. I think the reason it's become the gold standard is because it's been around so long and it's been used in a lot of clinical trials. And so a lot of the studies that we reference use this, and therefore a lot of the outcomes that were measured were used using this standard. And so it's kind of baked in to a lot of what we do in psychiatry. And so for better or worse, it is sort of the standard that things are compared to. And we'll look at some studies particularly that compare the Hamilton as performed by a psychiatrist to some of these other rating scales that are listed here. The Montgomery-Asberg Depression Rating Scale is kind of here for completeness sake, but it was developed a little bit after the Hamilton and kind of as an adjunct to that in research settings as well. The BDI-2 now is the newest version of the Beck Depression Inventory, which is a questionnaire, as opposed to things like the Hamilton, which are provider ratings of the patient. And the issue with this one is essentially that it costs money. It's proprietary, and as we'll see later, may not correlate as well to the Hamilton as we might hope. The inventory depression symptomatology and the quick inventory of depressive symptomatology are listed here. Of note, I just would point out that the quick inventory was designed sort of to be a parallel to the Hamilton, with the difference that it would be something that was administered by the patient, right? So another patient questionnaire, but kind of more geared to being in line with the results that you might get from the Hamilton as conducted by a psychiatrist. So as you can see from that list, the PHQ-9 again wasn't there. We're all sort of familiar with the PHQ-9. It's baked into EPIC, and essentially again was designed for primary care. And this is a study that was one of the earlier studies, if not the earliest, that I could find in 2001, looking at the validity of the PHQ-9 for assessing depression severity. It says, but essentially there's lots of studies about the PHQ-9, and it's pretty clearly shown that it correlates well with someone being diagnosed with depression by a mental health person or professional. And in this study, they looked at over almost 4,000 patients in a primary care setting, which included internal medicine, family medicine, and OBGYN, and then compared that to interviews conducted by mental health professionals. Of note, as you can see here, mental health professional was defined as one PhD clinical psychologist and social workers who work with psychiatric patients. So psychiatrists weren't really involved in this study. And in terms of rating moderate, or severe, what you see kind of in this chart is that the greater the severity on the PHQ-9 you rated, the more likely you were to get an official diagnosis of a depressive disorder by one of those mental health professionals, which makes sense. As a screening tool, you would want, to catch these people. But I guess the question kind of that I started to have was, well, someone's coming to see me as a psychiatrist. They may have already been admitted for depression. They may have seen several people in the past for depression. The question isn't really, do they have depression? Have we caught and screened for that depression? The question is, how severe is that depression, and how are they responding to our treatments? And I think that's a question that the PHQ-9 wasn't necessarily designed to address, but that the Hamilton was. So if we compare the Hamilton to the PHQ-9, just to kind of summarize some of the key points, the Hamilton, for better or worse, was kind of created for clinical trials and research. And one of the criticisms that I've seen posed was just that it was created for that purpose. And so it's more a tool to see if medications are treating symptoms that they're designed to treat. And that's a fair criticism and something to keep in mind when you're using it. You might decide that it doesn't encapsulate the whole clinical picture that you see as a trained psychiatrist. But again, I think it's all these rating metrics have pluses or minuses, and none of them replace clinical judgment. What I hope to show is that the Hamilton can be something that is valuable to you and as an additional tool and additional information. And one of the reasons I think it's valuable is the second point, that it's clinician administered. The PHQ-9 is usually performed prior to the patient seeing us and then pulled into most of our notes based on the templates we're using, which makes sense too if you think about what EPIC and other EMRs are sort of designed for. The most of the patients that are going to be seen in EPIC are primary care patients, and so it makes sense that those tools, which are very valuable in that setting, be kind of incorporated. And the question, that I have sometimes is, what does that score mean? Does it reflect what I'm seeing? Sometimes someone might fill out all 3s for the PHQ-9, but that doesn't necessarily mean that anything more than they just wanted to talk to someone and for someone to listen to them. Sometimes they're not sure of the date ranges. Right? They're sort of filling it out as, have you ever had these symptoms? And so what I often found was that I was explaining the results of the PHQ-9 anyway in my notes, particularly in outpatient, based on interviews with the patient. Right? And so to me, it's kind of nice to have a counter to that. You have a note now that says what the patient thinks about their depression, whether they kind of understood the questions well or not. It's kind of their say. And then you have the Hamilton, which is kind of the clinician's judgment of the situation, and is kind of there as a comparison and can be referenced to without having to kind of explain it in paragraph form necessarily why there were differences between the two. But also I think it helps kind of tracking back. to see if you were, have a snapshot of the patient that you saw 3 months ago, or one of your colleagues saw 3 months ago. You have kind of a detailed presentation of their symptomatology, because the Hamilton is based not necessarily exclusively on depression criteria from the DSM, but also lots of symptomatology that we'll get into when we go through it. So I think it gives you a quick shot once you get used to the scoring of kind of getting a clinical picture in your mind of what that patient was looking like, and it also kind of breaks down some of the symptomatology from previous encounters looking back through time. So this was a pretty big study that was conducted in the National Health Service in the UK. So they have the ability, given that they have a nationalized health system, to collect a lot of data and do sort of system-wide analysis. And what they wanted to do in this study was show that some of these metrics, like the BEC, like the PHQ-9, like the quick inventory, could be used by primary carers and other clinicians to assess the severity without them having to be trained or use the Hamilton Depression Scale. And the reason they want to do that is because not only do they have this large system, but they also have sort of national guidelines and treatment algorithms that are based on the severity. So it'd be really nice if we had these patient questionnaire administered tools that then could clearly dictate the treatment plan, whether you're going to increase the medication, change the medication, refer to psychiatry, things like that. One of the points I want to make sure we're clear about is that it's kind of assumed here that the Hamilton Depression Scale administered by a psychiatrist is the standard that we're comparing all these things to. Right? So every one of the patients in this study were also seen by a psychiatrist and administered the Hamilton, and the whole point was to see how well they compared to that. In the end, none of the metrics that they looked at compared favorably enough to the Hamilton or were consistent enough with the Hamilton to be used in their practice. They couldn't replace that metric. Of note, the PHQ-9 tended to rate severity of depression higher than the Hamilton administered by psychiatrists, which kind of makes sense for a screening tool, right? Like you would want it to be more sensitive and less specific. But in terms of a tool that you're using to measure treatment progress or severity of symptoms to recommend increase in medication or changing medication, you would want a tool that was more specific to that. And right now, for better or worse, the Hamilton's kind of seen as that tool. And one of the reasons that that's the case is simply because so many studies have used it for so long that the data that we're using to come up with these algorithms or treatment plans are essentially baked into to using the Hamilton. This is another study by the same group with other patients and similar results. So just to kind of summarize those points, essentially given the wide use in clinical trials and research, the Hamilton administered by a psychiatrist is often considered the best assessment for depression severity and therefore then treatment response to that. And thus far, the data, at least in the literature, is inconclusive at best and somewhat clear at worst that these other metrics don't compare favorably enough to the Hamilton to supplant that. PHQ-9 has been effective at screening. There's also studies that show that it's effective at screening for suicidality in conjunction with the Columbia Lighthouse or the depression studies. And again, there was lack of adequate correlation with the Hamilton, specifically with the PHQ-9, with the PHQ-9 rating depression more severely than the psychiatrist using the Hamilton did. So that's kind of the reason I think it's something to consider. Again, nothing should replace your clinical judgment. I think this is definitely a tool that could give you more information, or at least different information than the PHQ-9, and something that you can decide over the time of using it whether it's a valuable tool to you or not. To help you with this, I created a dot phrase that's called .hamd17. and I've shared it with all the residents in our department. It's ready to use, and if you have any problems with it, please let me know. But um, basically, I've created
the experience further.
All right, this phrase, and it creates essentially the Hamilton with drop-down menus for each topic that you can see here. Just want to point out here that I'm doing this really slow in this video, and it's taking about 5 minutes and 40 seconds to kind of click through everything, which, as we'll see, feels like it takes forever when we're engaged in a talk like this. But in the course of a 30-minute patient encounter, or in the course of an interaction on the inpatient unit, that's not actually that much time. But I would also argue that no one's going to click through this as slowly as I'm doing right now. So in reality, I've found in my clinical practice that it only takes a matter of minutes to get this information. Most of the information are things that we would get anyway. But I have created a document as a guide to help you in interviewing the patients. Essentially, it has recommended questions, first questions, and then sort of follow-up questions. But as you can see here, the Hamilton is asking things that we would normally be interested in, like mood, feelings of guilt, suicidal thoughts, and it breaks it down in ways that we typically do. For example, here in suicidal thoughts, we often ask, well, what are those thoughts like? Is it, do you feel like you're not worth living? Do you wish you were dead? Do you have ideas about have you tried things? And it gives more points, right, accordingly. As you can see here now, it also breaks down insomnia much more broadly than we typically do into early in the night, middle of the night, and early in the morning. So if you have difficulty initiating sleep, how big a difficulty is it? Do you have feelings of restlessness in the middle of the night? Do you get out of bed in the middle of the night because you can't sleep? And then, as we'll see here, do you wake up early, unable to fall back to sleep, gets out of bed, a little extra points for that. Most of the things that you'll see that we go through here are going to be things that you're probably already asking the patients and taking the time to document at times, but this kind of puts it in a nice organized manner and scores it for you. The things that we don't maybe always ask, that the Hamilton asks, are probably things we should think about asking more about anyways, as we'll see as we go through some of these. This section here is looking through basically anhedonia questions and scoring it kind of based on their level of activity. It also looks at anxiety symptoms, as you can see coming up here, both in terms of how the patient feels about their anxiety and as well as symptoms or kind of fidgetiness related to their anxiety and physical symptoms related to their anxiety, like whether they're having shortness of breath, things like that. As you can see here, it's noting scores for psychomotor retardation, which the PHQ-9 does, but it also has a section for psychomotor agitation as well here, and scores it kind of accordingly. With these two, number 8 and 9, they don't have questions associated with them. These are solely based on your observation as a clinician and giving you examples of things to look for and to be able to score them. So as you can see, we're ticking through here. It's been 3.5 minutes of me slowly clicking through here. I feel like once you get used to this, most of us would probably be done clicking through here by now. But I'm actually going to skip ahead because it's taking so long here. But you can see questions here for loss of appetite and actual weight loss, they're sort of being forced to eat, or whether you just, or others are urging you to eat is kind of a way that they break down the eating. This is sort of headaches, backaches, or other symptoms that are somatic. You get extra points for more severe symptoms than that. And then this here is symptoms related to libido and menstrual disturbances that might occur, which we don't typically always ask about, but would be good to check in with our patients. This is an interesting number 15 here. We don't typically ask about sort of their preoccupation with their own health, but a unique feature of the Hamilton that's not necessarily in some of the other rating scales. And then loss of weight, and then the quality of insight round out the bottom. So we didn't even get through the whole 5 minutes there. I think that was probably way too long. in actuality, that most people would finish that a lot sooner. There was an article in 1988 that I reference here and that I used to create my handout for you guys that has tips for questions that you could ask, specifically for the different items. But again, I think you'll see as you look through it and get used to the dot phrase itself. Most of the questions are things you're probably already asking, and then you can just sort of click through as you're working with the patient, and then the rest. I think once you get used to it, you'll be comfortable using those questions that are provided and maybe coming up with your own as well. So just to kind of finish up, what I'd like to do is share this information with you like I did and share the dot phrase and encourage you all to use it, try it out, and then um, I have some PDFs that have the Hamilton for your reference, also um, the tip sheet that I'll email you guys as well. And then I'd like to survey you guys in about 3 or 6 months to see what you think of it, um, and get your feedback. So the best part probably for you guys is that for every survey that I get from you, I'll give you a $10 Amazon gift card. Your time is valuable. We get a lot of surveys. The fact that you would take the time to do my survey means a lot to me, and I think it'd be helpful to see if this is something that maybe we should incorporate into our clinic or our inpatient units more often. So that's a maximum of $20 that y'all can get. Um, so I have a last slide for questions, which we can't really do, but I just kind of want to use this slide to let you know some of the ways that I think it could be helpful. Um, for example, on an inpatient unit, assessing the severity of someone who's depressed when they get admitted would be something that would be easy to use with this tool, and kind of using it to track their progress to your treatments. On the other side, it could be used also for malingerers who maybe you don't think are really depressed, and you could sort of build a documentation to support that. Obviously, in the outpatient setting, I think it can be helpful, and over time might help you evaluate yourself in terms of how you're making decisions about the care for your patients. Sometimes we sort of do that on a gut feeling. Sometimes we're doing that based on the PHQ-9. But how would this change your decision making if you had another metric to consider? I also think it could be useful for sharing kind of the clinical picture a little more clearly to other providers and even ourselves when we look back on patients if they call and there's issues and we have to think back to what was going on in that visit. As you can see, kind of it's very, very comprehensive, and I think creates a nice picture of the patient clinically. Um, and then I think, like I said, in the outpatient setting, when you're comparing someone's PHQ-9 and maybe they're evaluating things a lot higher than you feel in the room, I think it's sometimes hard to capture that feeling in the room that you have with the patient, whether that's to your attending or to um, someone who might review the document later and wonder why you made the decision you did. I think the Hamilton does a pretty decent job of capturing that for you. And then I think it's already being used here frequently in ECT. So for those of you who are working with Dr. Hart using ECT, and we're doing the Hamilton anyway, I think this could be an easier way to do it by using the dot phrase in your notes. In any case, I appreciate everyone's time for listening to this. I hope it was helpful. If you have any problems with the dot phrase or the documents or any questions about anything, feel free to email me, and I'd be happy to talk to you about this or help you in any way that I can. And I appreciate your time, and I appreciate you considering using this. I appreciate you considering answering those questionnaires in the future. Thanks for your time again.